The newborn. When we speak of the newborn, we're going to talk about the transition of the newborn to the extrauterine environment, and talk. We're going to, if you really know the norms on a newborn assessment, then you're going to be able to identify the abnormal. And even if you don't know what it is, you can always get help. So knowing the norms is really important in a newborn assessment, as well as any assessment that you're doing. Keep pushing, honey. Here comes the instructions. Don't we wish? There's a picture of a newborn. Notice the hands and the feet are a little bit blue. That's totally normal. That's acrocyanosis. Baby's crying. It's got good movement. It's pinking up rather rapidly. You could tell the baby's still brand new because the cord is still attached. It hasn't been cut yet. There's still amniotic fluid on the newborn as well as blood. Brand new newborn, I see that, and I'd say that's a pretty good little baby. It's adapting to its new environment quite well. So when we talk about care management of the newborn, our focus is really on assessing and stabilizing the infant. It's important that we wear gloves, at least until the baby's first bath, when the blood and the amniotic fluid are removed. That's for your safety as well as the baby's. And again, whenever we're talking about the newborn, it's really important to be aware of the prenatal history and interpartum history, meaning, during the prenatal, did they see anything in the ultrasound? Did the lab show anything? And was there, in the intrapartum, in the labor and delivery, was there any fetal distress? Because that would get us prepared and give us insight to any risk factors that might occur when that baby comes out and takes its first breath. So looking at the history, looking at how the baby tolerated labor is a really good, gives us good insight in how to handle this newborn. When the baby first comes out, we give it an initial score, an APGAR score, and basically what the APGAR score is telling us is how well the baby is adapting to the extrauterine environment. We can also do a gestational age assessment. Maybe the baby says the chart said the baby was 38 assessments, but we can look at the skin tone and the color and some of the features of the baby to see if actually that baby is 38 weeks or maybe it's 1 to 2 weeks younger or older. I would say with ultrasounds, the gestational age assessment given to the babies prior to birth is pretty accurate, pretty right on. A physical assessment, we do head to toes on our baby. Again, it's important for us to be aware of what's normal to detect what's not. You could tell immediately when that baby comes out. There's all this, anxiety just before delivery. There's a little bit of just the adrenaline rush because you're wondering if the baby's going to come out crying and screaming and moving around. You'll know as soon as that baby comes out. If that baby comes out and it's crying and pinking up and moving, then you know that baby is going to go straight to mama and it's probably doing fine. But if the baby comes out and it's limp and it's blue and it's not crying, it'll go to the warmer and probably we begin resuscitation immediately. The APGAR scores are given at 1 and 5 minutes, and we do not wait. The APGAR score is just telling us how well the baby's adjusting, but the resuscitation would begin immediately. The most critical physiological change that is required by the newborn is the baby now has to breathe and maintain respirations. Think about the baby in utero. The baby has the cord. The mom is giving the baby oxygen. The mom is, the baby basically doesn't have to rely on its own breathing to get oxygen, and the baby gets nutrients right through the cord. So now the baby is born, and now somebody has cut the cord, and now the baby has to breathe on its own. It's got to get its own oxygen. So there's multiple changes that need to occur at the time of birth. It's pretty amazing too. Again, if the newborn is breathing, it's pinking up, and there's no apparent life-threatening abnormalities, we dry off the baby on the abdomen, the cord is cut, and the baby is put skin to skin with mom for bonding for at least 1 to 2 hours after birth. The APGAR score is the rapid assessment of how well that baby is transitioning to the extrauterine environment. We do it at 1 in 5 minutes, and it's based on 5 signs that indicate physiological state of the newborn. It doesn't predict the neurological outcome, but it's just describing the transition to the extrauterine environment. When we do the APGAR scores, we're really looking at what is the baby's heart rate. We use the stethoscope. We can palpate the umbilical cord, but it's a little bit more difficult. Sometimes we do that in resuscitation. But if you were in the clinical setting, you would assess by listening to the heart rate with the stethoscope. We observe the chest for the respiratory effort to get respirations. We look at the muscle tone by the degree of flexion and movement. We look at the reflex irritability as the baby's response. Like if I did the bulb syringe in its mouth, is it going to pull away, or is it just going to grimace, or is it not going to do anything at all? It would be like if I put a bulb syringe to your nose, you would back up and probably want to slap me or something, because that's your reflex irritability. If you were really sick, or if you maybe were in bed and maybe comatose, you may not respond at all, or you just may grimace with your face. But basically, the baby should be sneezing and coughing, and if you try to suction him, it should be pulling away. The skin color is based on an observation, and these are the 5 signs that we use at an APGAR score. And here it is. APGAR: A is for activity, the muscle tone; P is for the pulse or the heart rate; G is for the grimace, the reflex irritability; A is appearance with the skin color; and R is for respirations. So basically, at a muscle tone, if the baby comes out moving and actively moving and tone is good, it's going to get a score of a 2. If the heart rate is above 100, because the normal baby's heart rate is going to be the same as it was in utero, which is 110 to 160s, but if it's above 100 as it's transitioning, it's going to get a 2. If it's sneezing and coughing and pulling away when you try to use the bulb syringe or suction, it's going to get a 2. If the baby is pink all over, it'll get a 2. And if the baby is crying, it's going to get a 2. So a perfect score on an APGAR score would be a 10, although I will say that I just mentioned that babies' hands and feet are sometimes blue, and that is acrocyanosis, and that is normal for the first 24 hours. So in reality, a 9 is probably going to be perfect for a baby, a 9 out of 10. 8 out of 10 would probably be off for color at the first minute, but then the baby pinks up and then maybe has some acrocyanosis if it was an 8, 9. Let's see. So let me see. If baby comes out, maybe his arms and legs are flexed, but he's not actively moving. The heart rate is below 100, but you still have a heart rate. There's a grimace reaction when you try to suction him, but he's not pulling away. If the body is pink, but the extremities are blue or acrocyanosis, that would be a 1. And if the respirations are slow and irregular, that would be a 1. So if the baby got a 1 all the way across the board, its APGAR score would be a 5 and would need to be repeated again in 5 minutes. And maybe if it didn't improve again, it would need to be again at 10. So we do APGARs at 1 minute, 5 minute, and if the 5 minute is not good, we'll do another 10 minute. If the baby comes out with no muscle tone, it's limp, there's no heart rate, there's no grimace or no response, and the baby is blue, gray, or pale all over, and there's no respirations, that baby would get a score of a 0, which basically would mean the baby is pretty much not surviving. A good APGAR score would be an APGAR score of at least 7 or above. And most of the time, if you're going to a normal, healthy baby that's transitioning well, will probably just get knocked off for a little bit of color. Of acrocyanosis, which is totally normal. So let's say the baby comes out crying, pinking up. It has acrocyanosis, but it's kicking and coughing and sneezing, and its heart rate is 110. What is the 1 minute APGAR? And do we need a 5 minute APGAR? And do we need a 10 minute APGAR? So yes, the 1 minute APGAR would be a 9. It would be taken off for acrocyanosis. We would need a 5 minute APGAR because we do every baby's at 1 in 5, but we would not need a 10 APGAR if the 5 APGAR was good. When we talk about the baby's transition to the extrauterine environment, A lot is going on. The baby now has to breathe for itself. It has to eat. So it has to suck. And it has to do a lot more than what it was doing in utero. But the baby has been growing for 40 weeks inside the uterus to prepare for this big day. And so it shouldn't have much problems in transitioning. We kind of talk about the transition period when the baby first comes out, the first 30 to 60 minutes. It's called the first period of reactivity, and that's the baby when the baby's alert. It's actually looking for food, and it's got a lot of activity. Then after that first period of reactivity, it kind of goes to sleep. And then when it wakes up is usually when it's awake again, and it's going to have its first bowel movement and look again for some food. We look at this, and really what we learned from this is if the baby's first period of reactivity, the first hour of life, it's alert, it's oriented, it wants to bond, and it wants to eat. That's why we want to initiate breastfeeding within that first hour. If we wait past the first hour, then the baby's in a period of decreased responsiveness and may not want to eat, and mom's first experience of feeding may not be optimal. We encourage skin-to-skin contact. The baby will cry less. The baby will actually, skin-to-skin contact maintains body temperature. It balances it with mom's. The glucose levels remain better. It induces calmness and relaxation. It actually awakens the breastfeeding reflexes. It allows optimal time for maternal and infant bonding so that there's attachment that occurs. And actually, there's studies that says there's increased sensitivity of the mother to the baby as measured as much as 1 year later. And there's better self-regulation, meaning the baby's up better on a sleep-wake pattern and eat. When we talk about the neonatal period, we're talking about the birth through the first 28 days of life. Again, there's many physiological and behavioral adaptations to the extrauterine life. Interesting enough, the lungs and liver are pretty much non-functional. They're not needing to be functional during fetal life, but now they must come into life. The behavioral changes or tasks of a newborn is when the baby is in utero, it's a nice, quiet, relaxed intrauterine experience. There's fluid, it's like floating in the water. There's nobody touching them. There's no bright lights. There's no passing the baby from person to person. Once the baby is born, think about it now. All the bright lights are there. We rub it off. We dry it off. We put it on mom. Mom gives it to dad. The nurse takes it. So there's a lot of stimuli. There's multiple stimuli going on, and the baby somehow needs to process it and store it all and organize it. And we all know that there are some babies that can handle that. They can sleep during a lot of noise, and there are others that have a harder time in processing, storing, and organizing all that stimuli. And also what the baby needs to do, though, is in addition to process and store and organize all that multiple stimuli that's going around them, is to actually establish a relationship with the caregivers and the environment. So that's one of the behavioral tasks of the infant. There are several physiological changes of the newborn, and we already talked about the most critical is the respiratory or the initiation of breathing. So now the baby needs to breathe. If we look at this baby is a little bit blue, could be some bruising, but it is crying. It's got good flexion. The cord's been cut. The clamp is on the cord. We would just watch and see what happens with that color, or possibly it could be some bruising on the baby due to the rapid descent or birth process. This baby looks like it's adjusting really well. The baby is pink. It looks like it's either yawning or crying, but looks like they're assessing with a heart rate. But this baby looks like, as far as respiratory, it's crying, it's pink, and it's doing pretty good. When we talk about respirations, once they start breathing, should be between 30 and 60 per minute once breathing has been established. Interesting enough, breathing is not new to the newborn. Even though they're not getting oxygen by breathing in the utero, they're actually practicing breathing movements continuously in utero. And when you do an ultrasound, you can actually see the baby moving around and actually practicing breathing in utero. When the newborn first starts to breathe, the pattern is kind of an abdominal breathing that's synchronous with chest movements. So it sounds like it'd be easy to get respirations on a baby, but actually respirations and the heart rate is a little bit more difficult on an infant than it would be on an adult. At delivery, the lungs must now be established as the site of gas exchange, whereas before, remember in utero, they were getting all the oxygen through the umbilical cord. Now that the baby's born, the umbilical cord has been cut, the lungs need to expand, surfactant is released and stimulated, and the baby will begin breathing. Again, this is the most critical physiological change of the newborn, the initiation of respirations. Some signs of respiratory distress on an infant would be nasal flaring, retractions of the rib cage, grunting with expiration, which is what kind of sounds like that would be grunting. There's changes in color that indicate respiratory distress. Acrocyanosis is normal in the first 24 hours, but cyanosis would be a blue baby. That would not be. There's also many changes that occur with the heart, and mainly because in utero, the baby does not send the blood to its lungs to get oxygen. It picks up oxygen from mom. Now when the baby is born, it needs to start respirations, but it also needs to send the blood to the lungs and come back and then distribute it throughout the body. So the heart has many changes that occur. Most babies, if they go into cardiac arrest, it's almost always caused by respiratory arrest, not by the heart. So we really concentrate on respirations with the baby. There's primary changes that occur in the heart. There's the expansion of the collapsed fetal lungs with air, and then, of course, there's loss of placental blood flow. So those are the things that stimulate many of the changes. Those are the primary changes. The secondary changes are the things in the heart. We'll talk about the ductus venosus, the ductus arteriosus, and the foramen ovale. Basically, the shifts in pressure in the heart and the lungs closes these umbilical vessels, the ductus venosus and arteriosus in the foramen ovale at birth. So it's just the changes in pressures with the baby now breathing and having to take the blood to the lungs and then come back to the heart and then distribute it throughout. All these changes in pressure stimulate the closure of all these vessels that used to be opened in utero. The ductus venosus is the connection of the umbilical vein to the inferior vena cava in pregnancy. Once that cord is cut, there's no blood coming through it, so basically it will close. The ductus arteriosus during pregnancy, it's opened up, and basically it's shunting blood from the pulmonary artery to the descending aorta, which is a necessary part of blood circulation in utero. But at birth, it's functionally closed almost immediately, and then once it's closed, the newborn will, as the newborn adapts, it closes immediately functionally after delivery. But it takes a few days to really close entirely on it, to its own. So it starts to close, but there's a little bit of an opening, and then in a couple of days later, it will be closed forever. Sometimes, though, that ducteriosus remains open, and it's referred to as a patent ductus arteriosus. It is more common in premature babies. It's kind of rare in full term, but that abnormal opening causes too much blood to circulate to the lungs and heart, and if it's not treated, the heart may weaken. Many times it will fix on its own, but sometimes if the heart is weakened, the baby may require heart surgery. The foramen ovale in utero allows blood to flow directly from the left atrium to the shunting from the right to the left atrium. It's open in utero, but once the baby is born, due to pressure changes, it closes. And the permanent closure will happen within a few months, but it functionally closes at birth and then permanently in a few months. The increased pressure in the left atrium and decreased pressure in the right atrium, which causes closure of the valve over the foramen. So basically, the foramen ovale, the ductus arteriosus, and the ductus venosus were all open in utero due to intrauterine blood flow. Once the baby is born and takes its first breath and all the pressure changes occur, it closes those valves and then allows the blood to circulate to the lungs to pick up oxygen from the baby breathing, and then to come back to the heart to go out throughout the whole body. Here we have the ductus arteriosus up here. We have the foramen ovale right here. I don't know if you can see it. And then on the bottom there, you can see the ductus venosus. I'm not going to get too much into depth. Some of your quizzing might, but just know that the heart needs to adapt to the extrauterine environment by the ductus arteriosus, the ductus venosus, and the foramen ovale closing, and they close due to shifts in pressure. Fetal circulation inside utero is less efficient at O2 exchange. So in utero, the fetus needs additional RBCs to transfer the O2 in utero. So therefore, the level of RBCs, hemoglobin and hematocrit are usually higher than those in the adult, but these levels will fall slowly over the first month. So in fetal circulation, there's more RBCs that are needed to transport the O2. Just keep that in mind, because once the baby is born, the body doesn't need all those RBCs, or the baby doesn't. So what happens is the baby's body breaks it down and needs to get rid of it. And when we talk about jaundice, it has a lot to do with the breakdown of those RBCs. And we'll talk about that a little bit later. A white blood cell count of 18,000 is normal at birth. Babies do not tolerate infection very well at all, so we try to keep our babies safe. Platelets are pretty much the same in newborns as adults, and their blood groups are genetically determined and established early on. So early on in the pregnancy, we can see if they're O positive, or Rh negative, or the O positive, or whatever. We don't know what they are unless we test the blood, which we will once the baby is born, but it's genetically determined already. There's lots of changes in the newborn, and one of the things is now the baby needs to regulate its own temperature. In utero, mom does a really good job of that. The amniotic fluid keeps it at a certain temperature. The baby doesn't need to worry. Now it's out in the big bad world. It's all wet, gets cold, and it needs to learn how to regulate its temperature. We know when babies get cold, it's extremely dangerous. We know that babies don't like to be cold, but babies have their own way of making themselves warm, and they have a way of generating heat. We know that we as adults, when we get hot or we get cold, we shiver, and it's a way of keeping warm. Babies don't shiver, but they do burn brown fat to keep warm. That's their way of making heat, is burning brown fat that they're born with. But we watch our babies very closely because we want them to adapt to the external environment, but we know that they have to learn how to adapt to the temperature changes. So we try to keep our babies from losing heat, and they can lose heat through 4 modes, which is convection, radiation, evaporation, and conduction. And we'll talk a little bit about those. But basically, a baby's thermal regulation is the maintenance of balance between heat loss and heat production. And so that's what we refer to as thermal regulation. We try to prevent hypothermia because that can be very dangerous to our babies. In Arizona, of course, we also have to be concerned with babies getting too hot, so we have to educate our parents about car seats and taking the babies out and how fast they can overheat as well. Thermogenesis is in response to cold. The newborn attempts to generate heat. The shivering mechanism is not working in the newborns, so actually they burn brown fat. Heat produced in the brown fat can warm the infant. Cold infants sometimes cry. They appear restless. And their babies also are born with a thin layer of subcutaneous fat, which provides poor insulation. So it's really important we help keep those babies warm. Again, how do the babies lose heat? Because if we know how they lose it, we can try to keep the babies warm. Convection basically is the flow of heat from the body to cooler ambient air. Basically, what that's saying is you don't carry a baby that's totally naked, not wrapped in a blanket, because we do not want the air, the cold air to get it. And that would be convection, that cold air. So we wrap the baby in a warm blanket, and we put a cap on its head to prevent heat loss through convection. Radiation is more like at home in the cold states up north and northeast. Its radiation is the loss of body surface to a cooler surface area, not in direct contact, but in close proximity. Kind of like if you put a baby near a drafty window, the baby would get cold. We educate our patients to keep their babies away from drafty places or cold windows to keep the babies warm. In Arizona, it's just the opposite. We keep our babies away from hot windows to keep them cooler. And that's in the summertime. Evaporation is basically the loss of heat when liquid evaporates, just like when you get out of the pool, you're cold because the liquid's evaporating, or if you get out of the shower. So once the baby is born, we dry the baby off well so it does not get cold. Conduction is the loss of heat from body surface to the cooler surfaces in direct contact. Basically, if we did not pre-warm our warmers, if we had to resuscitate the baby, we would be putting the baby, a warm baby from the uterus, onto a cold surface, and that would take away some of the warmth of the baby. So we pre-warm our warmer, we pre-warm our blankets, so that baby will not lose heat from its body surface to cooler surfaces. So you can see how if we know how babies lose heat, we can prevent them from losing heat by taking care of those problems, by pre-warming the room, pre-warming the heater, keeping the baby wrapped in a cap on its head, and drying off the baby at birth. We do know for temper regulation, blood vessels are closer to the surface. There's a larger surface to body weight than adults, which causes sometimes the babies to get cold. When the babies do get cold, there's increased oxygen consumption and respiratory rate, which can lead to metabolic acidosis. Maintaining body temperature will prevent cold stress. Hypothermia also develops rapidly in newborns, which can lead to cerebral damage from dehydration and heat stroke, and that would be like in Arizona, a baby left in a hot car. There's many physiological changes of the newborn, and one of them is its kidneys. Kidneys are large at birth. We need to note and record anytime the baby voids. That first void is really important to chart and note, because once the baby voids, we know that the plumbing works. So we also record how many times the baby voids to make sure that the baby is getting adequate nutrition via breast milk or formula. And with breast milk, it would be from colostrum those first couple of days. That first void may be a little pink tinge. We call it brick dust, which is caused by uric acid crystals. Babies are made to lose a little bit of weight. They'll regain it in after a couple weeks in life. 40% of the body weight in newborns is actually extracellular fluid. Again, it's important to know the normal voiding patterns of infant. Usually that first day, they'll probably void at least once, the second day twice. By the time the milk is in on day 3 or 4, babies probably will be peeing at least or having wet and dirty diapers 6 to 8 times a day. That is something we need to educate our moms on. A lot of times moms, when they're breastfeeding, they are always wondering, I don't know if my baby's getting enough because I can't measure it. And we can always ask them, well, how many times is your baby voiding? How many times are you changing diapers on baby? If they say 6 to 8 times, we'll say, then you know that they're probably getting enough because they're peeing and they're pooping. Just like when you drink a lot, you'll be peeing a lot. So if the babies are getting enough, they're going to be peeing and they're going to be voiding and actually having bowel movements. The baby is born with special reflexes, which allows them to breathe, suck, and swallow to be able to feed. The baby will have stools. The baby's first stool is called meconium. It's kind of a black tarry. It's really sticky and messy. Once the milk comes in, there will be transitional stools and milk stools. Babies that are breastfed, their stools are kind of a yellowish, cottage cheesy appearance. They're soft and they're easy to pass. Whereas if a baby is on formula, it's more like little human stools, and babies tend to get constipated. It's important to document the first stool and document the characteristics and color, because if we document the first stool, we then know that baby's plumbing works in that department as well. Iron stores are usually pretty good for 4 to 6 months. Carbohydrate, the metabolism, decreased blood sugar initially, but usually babies do fine. We'll talk about large babies and the need to check blood sugars on them. and we're going to talk a little bit about bilirubin and physiological jaundice. And I'm going to stop this one at 30 minutes, and I will have a newborn 2 to finish this presentation.